So, all right. Good morning, Thailand. Thank you for allowing us to be here today. I think both Amy and I are very passionate about this topic, and we're pleased to present to you and have this discussion with you. So feel free to ask questions. Um, so the first part is going to be more didactic. I'll go through current research and evidence. And then the second part, Amy will do more of the hands-on what we do at OHSU. One thing that I always, so you can see our objectives, you may have gotten those in advance. I feel like the first part is pretty basic and might be a review for many of you. And then we'll go into some more of the evidence that we're working on when it comes to the complications of surviving breast cancer. The first part is that we're really focused on prehabilitation for breast cancer surgeries at OHSU. Prehabilitation meaning that we initiate rehab prior to any surgery. And one of the reasons that we want to do this is we want to establish baselines. We want to know if they have shoulder, arm, cervical spine range of motion that is within functional limits prior to surgery. We also want to assess strength with manual muscle testing, and we might want to look at grip strength with a JMAR dynamometer. One of the other interesting things, one of my colleagues and I often have a conversation about what is the worst complication of surviving breast cancer, and I always feel like it's lymphedema, but she argues that it's fatigue, and that fatigue causes people to require more caregivers and they can't return to work. And so oftentimes one of the things that we may want to take a look at in prehabilitation is a 6-minute walk test. And we also want to establish baselines knowing if the person already has pre-existing upper quadrant dysfunction. Maybe they already have a history of carpal tunnel. And so that's something that we might want to take into account when they're going through chemo. Maybe it's not necessarily a chemo-induced neuropathy. We also want to, and prehabilitation, besides establishing baselines, we want to encourage preoperative exercise routines in resistance exercise, mobility exercise, stretching exercise, and aerobic exercises. All of those are really important preoperatively, and I'm going to show you research why in just a minute. We might want to discuss a person's lymphedema risk, especially if they're known to have an axillary lymph node dissection at the time of surgery. We might want to talk to them about how to manage their scar after surgery and what that would look like and the timing of that. We also want to teach them how to care for their skin during and after radiation, and we can give them tips on how to do that. And we will also educate them on the risk of axillary web syndrome. All of these things, Amy will show you what we do and how we address this during treatment as well. So I feel like this is a very basic review, and you probably know this, but I'm going to go through it anyways. When we talk about the different types of breast cancer surgeries, a lumpectomy is where the surgeon removes the tumor and some of the surrounding breast tissue. The amount of tissue varies and depends on several factors such as the size and location of the tumor. And now in a lot more literature recently, it's called breast conserving surgery or breast sparing surgery. And so you'll see that later on as well. And then, I'm sure you've heard of mastectomy, where all of the breast tissue is removed. Some people elect to have immediate reconstruction at the time of mastectomy. And I will put a plug in for this because it has been shown that immediate reconstruction has been known to reduce the risk of lymphedema. The preposition is that there's less scar tissue. So maybe having less scar tissue will reduce the risk of lymphedema if somebody elects to have immediate reconstruction at the time of mastectomy. So you can have a simple or a total mastectomy, so the entire breast, which includes the nipple, the areola, and most of the skin. A modified radical mastectomy, where the lymph nodes are removed along with the breast tissue. I'm sorry, that's a modified radical. And then a radical is where they take the lymph nodes, the muscles under the breast are removed because oftentimes the cancer has spread to the muscles. And then you can have a prophylactic or preventative mastectomy, where one or both of the breasts are removed as a precaution for women at a high risk of breast cancer. So talking again about the nipple and skin sparing mastectomy, the surgeon removes the breast tissue through a small incision around the areola, which leaves a bit of an envelope. Um, and it has a more natural looking reconstruction when implants are placed. So a lot of people are electing for that as well at this time. And then when we talk about oncoplastic reduction surgery, that's when you combine reconstructive techniques along with the cancer surgery. So you might have actually two surgeons in the room. You would have the cancer surgeon and you would have the plastic surgeon. So the oncology surgeon would be removing the tumor and the plastic surgeon would be sculpting the breast tissue to make sure that the breasts are left symmetric, and aesthetics are really important. They might even do an oncoplastic reduction on the non-cancerous breast side. So let's talk about really quickly the difference between sentinel lymph node biopsy and an axillary lymph node dissection. Sentinel node, often in literature, refers to 1 to 5 lymph nodes are removed for sampling. One of the things that's really interesting here in the US and probably in Thailand as well is that there's neoadjunctive chemotherapy that's used prior to any surgeries to reduce the tumor. And that's been shown to actually reduce the cancer burden in the lymph nodes. So people who get neoadjunctive cancer treatment can often go from a pathologically positive lymph node to a pathologically negative lymph node. And so because of neoadjunctive chemotherapy, we're having more sentinel lymph node biopsies done than complete axillary lymph node dissections. So axillary lymph node dissection is anything more than 5 lymph nodes. The problem is that imaging is not reliable, and it doesn't detect micrometastases. So there always has to be some type of sampling in breast cancer. The disease status and the prognosis it's important to find out if there's cancer in the lymph nodes because it helps determine prognosis. And so even after someone has neoadjunctive chemotherapy, they still often do sentinel lymph node biopsy to help determine the next course of action. All right, so oftentimes if someone elects to have a mastectomy, and then decides not to have an implant, they can elect to undergo autologous breast cancer surgery. So they're donating the tissue to create a breast out of their own tissue. And oftentimes, the most common is the deep flap surgery because they use the deep inferior epigastric perforator blood vessels from the belly. They spare the muscle and the fibrous tissue called the fascia, and they move that tissue up to the breast to create a new breast for the patient. So the patient there's a lot less complications because the women retain their abdominal strength. And in some situations, they're now working on sensory nerve connections as well so that the tissue is sensate, which is actually really cool too, because a lot of people want to be able to feel where the tissue is. There's also, if the abdomen is not available for the surgery, they can do a tram flap surgery, which they move part of the transverse rectus abdominis. So that's along with the muscle, along with the skin, fat, and blood vessels. It carries a little bit more side effects and there's more precautions afterwards. And then there's the latissimus dorsi flap surgery, where they move the muscle, skin, and fat from the back, but they leave the blood vessels attached. So they pretty much just rotate the tissue around to create a breast. And then there's other types of flap surgeries as well. And so we at OHSU often get referrals to work on post-op swelling and loss of range of motion and scar management as well for these surgeries. So I'm going to go off on a little tangent here because I love this article. This was actually discussed at the 2021 Chicago Breast Surgery and Lymphedema Surgery Symposium. This article has been cited over 3,000 times by other journals, medical journals. So it's really highly revered in the medical field right now. And the reason is because it's a 20-year study that actually they started out with 11,000 participants in this study or subjects in this study, but because of, they had to narrow it down to meet the inclusion criteria, which they ended up having 700 patients. They specifically were looking at people who had early cancer, so they had to be node negative. And so out of 11,000 people, they ended up with 700. And they were comparing out of 700 who had a radical mastectomy to 352 patients who had breast conserving surgery. And they wanted to see what reoccurrence rates were and if longevity was affected. So what they found over this 20-year period is that there was local reoccurrence. And so 8 of the 349 people with the radical mastectomy experienced a local reoccurrence in the same breast, whereas 30 of the 352 patients with breast conserving surgery experienced local reoccurrence. 30 who had a reoccurrence in the breast conserving surgery, they would have a second surgery later on, or maybe another round of chemotherapy. But oftentimes they did not elect to go through another mastectomy. So, and what this study found was that there's no statistical difference in the incidence of contralateral breast cancer, distant metastases, or other primary cancers in either the radical mastectomy or the breast conserving surgery. So basically what they say is the long-term survival rate among women who undergo breast conserving surgery is the same as those who undergo radical mastectomy. And the argument is that those who have the breast conserving surgery actually have better outcomes and they have higher qualities of life. And so that it's not necessary if you have an early cancer diagnosis to automatically think that you have to have a mastectomy. But again, what they're driving home in this article as well is that early detection of breast cancer is essential. So, and one more thought is that a lot of women who elect to have mastectomies when they have an early diagnosis of cancer, breast cancer, they feel that a mastectomy will prevent reoccurrence of the cancer. But this journal article, this research study shows that most often cancer reoccurrence is distant reoccurrence. So it's not occurring in the breast with the initial or primary cancer. And again, you know, when do we start mastectomies in the US? I'm sorry, when do we start mammography in the US? It's not until a person reaches 40 years of age. But I wonder if that's going to change, especially like women who have who are at the greatest risk of reoccurrence, including distant reoccurrence. Any person under 40, any woman under 40 has a 2 times higher risk of reoccurrence than a person over 40. So why do we start mammography at age 40? I wish it was different. I wish we actually started mapping breasts at age 30 and then deciding at that point how often a person needs to have mammography, because I think this article shows how we can how to treat reoccurrence and how to and that breast conserving surgery is actually effective. Any questions so far? Because I don't know how to know if there's any questions.
There's one.
Okay.
For breast cancer survivors with preserved technique, have you found lymphedema in your experience?
Oh,
If found, is it less severe, the same for rehab management?
I love this question because that's leading into the next segment. So yes, I'm totally going to talk about this. And I have all of the data for you. I love that question. So I'll talk about that in a minute. All right. So, but before that, let's talk about one more research study that just came out in 2021. And this was funded by the National Cancer Institute. It was published in the Journal of the National Cancer Institute. And the study is called Diet, Exercise, Lifestyle, and Cancer Prognosis. So we know that there's a growing body of evidence that suggests regular physical activity before and after cancer diagnosis, is those people are less likely to have cancer reoccurrences. So this study looked at 1,340 patients, and these patients completed questionnaires at 4 points during their cancer journey. I don't know how they captured somehow the month before diagnosis, during treatment, and then at 1 and 2 years follow-up. So the study recommended that people participate in a minimum of at least 2.5 to 5 hours of moderate and physical activity per week. Or 1.25 to 2.5 hours of vigorous intensity aerobic physical activity per week. And so they asked people to rate their physical activity at 4 different points during their cancer journey, up to 2 years follow-up. So women who had breast cancer who met the minimum physical activity reported, that was recommended, both before and after diagnosis. So they participated in 2.5 to 5 hours of moderate intensity physical activity, or 2.5 to 2.5 hours of vigorous intensity per week, before and after the cancer diagnosis, had a 55% reduced chance of cancer reoccurrence and a 68% reduced chance of death from any cause, compared to those who did not meet any physical activity recommendations or guidelines. So that's pretty significant. The exercise, we know that there's a relationship between exercise and preventing cancer reoccurrence, and they're actually statistically telling us that there is. So those who did not meet the guidelines before diagnosis, but met them at the 2-year follow-up, by the way, and this is the thing, it's never too late, right? And this is probably what we talk to our patients a bit about, is it's not too late to start exercising. And this is why, even when we see our patients, this is what we're educating them about. Those who did not meet the guidelines before diagnosis, but met them at the 2-year follow-up. So even after they were diagnosed and then they started exercising, they had a reduced reoccurrence risk of 40% less, and reduced risk of death by 43%. So exercise is pretty crucial. At OHSU pre-COVID, we had an oncology exercise group that would meet with a therapist, and I think it was 4 people per therapist that would meet weekly. Since COVID, we haven't started that back up again, but I would love for us to restart that soon. All right, so I could probably spend 2 hours talking about lymphedema. That's another time. So lymphedema is a chronic protein-rich inflammatory condition of the lymphatic system where the lymph load, so what the lymph has to uptake, exceeds the lymphatic capacity to pump. The problem is lymphedema leads to pain, infections, A lot of people feel like they lose function of their arm, they have reduced quality of life, they feel like clothing doesn't fit the same, rings and watches don't fit the same. It's costly here in America. You have to get a sleeve, a compression sleeve every 6 months, but oftentimes insurance won't pay, doesn't reimburse for it. So they have to pay for their own compression garments every 6 months, which could be $90 each. And it requires lifelong treatment. And of course, so I feel frustrated because I think this is the greatest complication of surviving breast cancer. Again, it's debatable. Some people say fatigue is the greatest complication, but what we know, and this, depending on what journal you read, we can pretty much estimate that 1 in 5 people treated for breast cancer will get arm lymphedema. And we're now able to narrow down the risk though. So lymphedema risk is highest in those who have an axillary lymph node dissection. So technically that's more than 5 lymph nodes. They undergo radiation. They have a taxane-based chemo, because remember, anti-cancer therapies like a taxane-based chemo, they have a negative impact on body composition because they induce muscle wasting. So a lot of our cancer patients feel like they gain weight. And I kind of feel like, well, it's because your muscles are wasting. I'm getting a message on the screen really quickly. That someone is wanting to annotate the shared content. Do you see that?
No, but can you say no?
I can decline.
Yeah.
So again, highest risk group of who will get lymphedema: axillary lymph node dissection, more than 5 lymph nodes, radiation, taxane-based chemo, and obesity. So those who have a BMI greater than 30 and are undergoing cancer treatment have a higher risk of getting lymphedema than those who have a BMI under 30. So again, this is why we do prehabilitation. We want to talk about exercise, and if they have a higher BMI, we might want to suggest how exercise will help reduce weight and reduce the risk of lymphedema. And then I'm going to talk at the very end about new studies that show anyone with a BMI over 40 might actually induce lymphedema in a non-oncology related health problem. So typically lymphedema occurs in the first 80% of lymphedema. Of those 25% who are going to get lymphedema after cancer surgery or cancer treatment, 80% will occur within the first year after treatment. And this is why when we see someone for prehabilitation with a known that we know they're going to have an axillary lymph node dissection, we know at that point that we are going to follow them for 1 year. And I'll talk about that in a minute. But 80% of the 95% of people who will get lymphedema after breast cancer treatment, 95% has shown up by the first 3 years. Does that mean after 3 years, do you not stay vigilant in taking care of your arm or exercising? No, you still want to be aware that lymphedema is a risk. But by 3 years, lymphedema should have, if it was going to, show up already. But after 3 years, the risk is very small, but still be vigilant is what we tell people. And actually, if you're interested, I can break down even more because I love the question, do we know that sentinel lymph node biopsy reduces the risk of lymphedema? It's actually, if a person had a sentinel lymph node biopsy and no other cancer treatment, the risk of lymphedema is actually 3 to 5%. If they had some sentinel lymph node biopsy and regional lymph node radiation, the risk is 7 to 10%. If they have just an axillary lymph node dissection and no radiation, that's where we see the risk of 20 to 25% risk. And our highest risk group, again, is the axillary lymph node dissection. So more than 5 lymph nodes. and radiation. That puts somebody at a 25% to 40% chance risk. And again, immediate breast cancer reconstruction has been shown to reduce the risk of lymphedema because the suggestion is it creates less scar tissue, so less blocking of the lymphatic system's ability to for lymphangiogenesis to occur. It doesn't impede it as much. I'm seeing there's some more questions. Um, Oh, I love this question too. Okay, so I'm looking at another screen and it says now there's BRCA1 gene responsible for breast cancer if detected. Is it recommended guideline now in the US to do preventive mastectomy like what Angelina Jolie did? Or is it still individual based decision? It is still they are having is still in the US if somebody is detected with the BRCA gene. They are advised to have both a mastectomy and oftentimes the total abdominal hysterectomy with the oophorectomy because they have a high chance of cancer in the reproductive organs as well as the breasts. So yes, it's still happening, and I think both Amy and I probably still see women in their 30s with the BRCA gene who are having these recommended surgeries. So that's a great question. All right, oops, why did it not go? Sorry, I'm trying to advance. Oh, there we go. Okay, so again, when we know someone is at the highest risk group for having breast cancer related lymphedema, we see them for prehab, so we see them before surgery. We see them at 3 months, 6 months, 9 months. We see them, and up until 1 year, we see them every 3 months, and we monitor them for breast cancer related lymphedema. So here are some things that when we look at. If we also want to consider the stages of lymphedema. And what I love is I put our stages, what we look at as far as lymphedema here at OHSU, I put our stages down at the bottom, but you can go to Japan. They have a different staging technique. Australia has a different staging technique. Brazil has a different staging. And so MD Anderson has a different staging lymphedema staging. And so there is an international lymphedema society, the ISL, and they're trying to make staging consistent around the world. But here at OHSU, one of the things that we know for certain is that there is a stage 0. This is before there is clinical symptoms. There is a subtle change, a subtle increase in the extracellular fluid content, but it may not be measurable. But the lymph transport capacity is already reducing in stage 0. And we want to catch people in stage 0 lymphedema. Sometimes we'll say, you may not see any swelling in your hand or behind your elbow, but you might feel a slight skin tightness. You might feel like your rings don't fit. You might feel like your sleeve, the cuff around your sleeve is a little tight, even though you don't see any swelling. So we want to educate patients to pay attention to these really subtle changes. And if they do detect that, they usually let us know and they come in for an additional surveillance. And we'll talk about that in a minute as well. But stage 1 is considered reversible. And it's only considered reversible because it reduces with elevation. And at this point, the extracellular fluid that is in the interstitial space is really soft, and you can see pitting when you push on the skin. This is in stage 1. When we get to stage 2, it's no longer reducing with elevation, so it's called irreversible lymphedema. And and it partially improves with treatment, but we still will never probably be able to get it back to pre lymphedema. And the problem with stage 2 is that extracellular fluid in the interstitial space is no longer soft and pitting. It's now becoming fibrotic. Whoops. Somebody keeps wanting to annotate. I'm going to decline that again. Okay. And then by stage 3 is when we have elephantiasis. I haven't seen that in the arm.
No.
I feel like we don't see that in the arms here. And the classic description of elephantiasis is where you have morphologic skin changes. And the swelling is so fibrotic that there is no pitting. The swelling is so hard, you can't actually indent the skin. And so really significant fibrosis is present in stage 3. But we can take this a whole nother step further because, and even here at OHSU, we have indocyanine green lymphangiography. And indocyanine green is a biofluorescent dye. So it's injected subcutaneously in the hand, and they use a light to follow how long it takes the lymph to transport that fluorescent dye, the indocyanine green, up the arm and all the way to the axillary lymph nodes. So it's measured in time. So they do both arms at the same time, and they measure where the lymph is going. And also not only where it's going, but where is it backflowing? So where oftentimes the lymph may be Everybody okay?
Yeah, I think we are okay. So you can.
So it's, so the vessels are blocked at the axilla. But with indocyanine green studies, they can see where the lymph is backflowing into the cutaneous space. So where there is dermal backflow. So the ICG lymphangiography is also used to stage lymphedema. And they use 5 different stages. So, and I think it's interesting if we go through those 5 stages, you can see what changes. So in stage 0, the lymphatic vessels are open and there is 0 backflow. There's no dermal backflow seen. And you can tell in the ICG lymphangiography that the lymph vessels are contracting. So there is the lymph angion activity is occurring. In stage 1, the vessels become more occluded. You're starting to see a little bit of a dermal backflow and the vessels aren't contracting as well. On stage 2, you can see it consistently declines. The vessels become even more occluded. There's even more dermal backflow and the vessels are contracting less. All the way until you get lymphangiography, and you can see, and I think this is so interesting, is get to stage 5, there are no patent or open lymph vessels. And there's no, it's all occluded. The vessels themselves become sclerotic, like scar tissue. So it's really hard. There's no surgical intervention for lymphedema when there's impatent lymphatic vessels. And then you can see that there's no contractibility of the lymph vessels as well. Let's see. So I'm looking if there's any questions.
I'm not sure.
So let me know if there's any more specific questions. I see comments, which are cool. Thank you. Okay. So continuing, again, breast cancer-related lymphedema surveillance is important preoperatively to establish baselines. Again, at 3 months, 6 months, 9 months, and 12 months. And if at any point a person detects subclinical lymphedema, something doesn't feel right, something feels heavy, they usually let us know so we can get them in sooner and do additional testing. When we do our surveillance, we look at symmetry, we look for pitting edema, we look at the vasculature. Oftentimes after radiation, people have discolored skin and they have really pronounced superficial blood vessels, which is called telangiectasia. So we might want to document that as well. We also look at the Stimmer sign. Are we able to pinch their skin away from the fascia below? It's not always 100% reliable in lymphedema, especially on the fingers, but we might want to modify it and see if where on the arm, if we can get a positive or a negative Stimmer sign. At OHSU, we're really fortunate because we have bioimpedance spectroscopy. So this is going to be the next segment of what we talk about. We can convert, we take tape measurements as well in segments up the arm, and we can convert that to a limb volume. So we might, but we expect after surgery, limb volume is going to change. So it's really important. It's hard to compare the arms after surgery because we expect changes postoperatively that end up going away. So we need to establish baselines preoperatively. We also know that 28% of arms have asymmetry. So we can't really always rely on comparing left and right after surgery. But I think one of the more reliable prehab assessments is the bioimpedance spectroscopy, which I'm going to go over next. Anyways, again, when we look at what is clinical lymphedema, we need to determine what change in volume and limb volume do we think lymphedema occurs in. Most often is when the relative volume changes greater than 5%, and they have the subjective symptoms of skin tightness and their limb feels heavy, their sleeves feel tight, their watches are tight. So that usually corresponds to an increase in the relative volume change. And of course, we expect that there's going to be a change after surgery anyways, that, probably for 3 to 5 months, they might have slight more postoperative swelling. When we do our surveillance, again, always going back to education, why we do what we do. I usually direct them, I think Amy and I both usually direct them to the Lymphatic Education and Research Network. That organization actually has been responsible for hosting several international symposiums. And they also apply the credentials to lymphatic centers of excellence. And we're really fortunate at OHSU that we actually right now have the highest level of credentialing as a lymphatic center of excellence. I included the website on this slide because I love the research and the information provided here. So you can direct your patients to find out that you can have PDF forms of what is lymphedema, facts about the lymphatic system, facts about lipedema. Even on this website, if you put into the search and you did 10 and you searched for 10 things, they have 10 things I want my physician to know about lymphedema, 10 things I want my caregiver to know about lymphedema, 10 things I want my doctor to know about lymphedema. So they have some really fun documents that patients feel that they can relate to. Okay, bioimpedance. So at OHSU, we have this bioimpedance spectroscopy device. It's a SOZO device, and it is made by ImpediMed. And I included the website. I contacted ImpediMed several times to find out who the Southeast Asia representative is, and they assured me there was one, but they never gave me the contact information. So it would be interesting if you were able to contact someone through ImpediMed to find out more about this device. But this is pretty crucial to breast cancer-related lymphedema surveillance because it uses a 30-second painless electrical signal to analyze a patient's extracellular fluid, which is where the lymphedema typically shows up. And then they compare that to a person's intracellular fluid and a patient's total body water. So when we do a SOZO test to get the LDEX score, the LDEX is the score, which is the difference between the extracellular fluid from the at-risk limb compared to the unaffected limb. So this is the LDEX score. So we're really interested. It does a lot of other different body segment analysis, but we think the LDEX score is crucial to determining if someone has subclinical lymphedema. In fact, it has been shown, and this will be on the next slide, it shows that it can detect subclinical lymphedema 4 to 10 months before a tape measure assessment would detect subclinical lymphedema. And so what we look at, and I'll show you here on the cursor, a normal LDEX score. So when we compare the extracellular fluid of the at-risk limb to the unaffected limb, normal range is -10 to 10 for the LDEX score. So this person had like a 2.3. I would say, oh, that's normal. That's your baseline. So we see them at prehab, and we automatically do a SOZO assessment. And we say your LDEX score is 2.3 at baseline. And so then if a person's score, if they call us up and they say 6 months later, they say, hey, something feels weird about my arm, something doesn't feel right, my skin feels tight, and they tell us, we'll fit them in and try to get another SOZO assessment. And if that 2.3 changes by 6.5, then we're concerned that this person has subclinical lymphedema. Okay, and over time, we can see that this person has an established baseline of 2.3, and it's slightly going up. And then I can't really see the numbers that well, but let's say over time, they have a spike of more than 6.5. And we're like, oh, wow, it looks like you have subclinical lymphedema. We need to trigger intervention at this point. And so this is when we say you must wear a compression sleeve a minimum of 12 hours for the next 4 weeks. And let me go into the research of why we say that. So in 2022, we've known about this research for a while, but it finally got published last November. And we call it the PREVENT study. This is what SOZO's been referring to, or ImpediMed refers to the PREVENT study. It has a large multi-center randomized controlled trial. In the final analysis, so when they broke down all of the inclusion criteria, they were able to study 879 patients who were at risk for breast cancer-related lymphedema. And out of those, they were able to split these two into a group that would have the bioimpedance spectroscopy and a group that would have the tape measure. And so they ended up breaking it up to 442 had the bioimpedance spectroscopy, and then 437 had the tape measure assessment. And so they also, if they were worried about a person that was starting to develop lymphedema, they would always divert and then have them wear compression for 4 weeks for 12 hours. Compassion among people who have symptomatic complaints of lymphedema, but anyone who had on bioimpedance spectroscopy, if their LDEX score increased by 6.5, they would automatically trigger intervention, which would be compression. If the tape measure volume increased by 10%, those people would trigger that they would need a compression sleeve and a gauntlet for 4 weeks for 12 hours per day. So out of these two groups, they looked at who improved after the 4 weeks and who needed to go on to get complete decongestive therapy. So they were looking at, did the lymphedema appear to resolve when we had early detection of subclinical lymphedema versus of those people who had a tape measure, a volume change, what happened after that? So of the initial 879 patients, 209 triggered intervention. Okay, so 89 of those 209 were triggered, had a triggered intervention for bioimpedance spectroscopy. So 89 had an increase in their LDX score by 6.5. And those who were having the tape measure assessments, 120 trigger intervention meaning compression sleeves for 4 weeks. What's interesting is of that group, so of those 209 patients, 30 of them progressed into chronic lymphedema. And what's even more interesting is of those people, of that 30, only 7 were from the bioimpedance group and 23 were from the tape measure group. So that clearly shows us that early detection of subclinical lymphedema may actually prevent the progression into chronic lymphedema. So it's a very exciting study. And the SOZA device is actually used for other things as well. It might detect congestive heart failure. It may detect renal failure because it's looking at extracellular fluid and total body water. So there's a lot of different things that it can be used for, but we love using it to detect subclinical lymphedema, which triggers early intervention. So again, the study supports that prospective breast cancer-related lymphedema screening is important. So prehabilitation is important, especially coupled with early intervention. Early intervention is 4 weeks of compression use for 12 hours a day. And it reduces the progression of lymphedema to chronic lymphedema compared to tape measure assessments. And they think that it's because bioimpedance has the ability to detect increases in extracellular fluid before it's measurable. Again, it detects lymphedema 4 to 10 months earlier than circumference measurements. So that really bioimpedance should be the standard of treatment for early detection of breast cancer-related lymphedema. And what we know as therapists is that when someone starts having symptoms of subclinical lymphedema, we always go compression and exercise. We want you to do compression and exercise. And this study drives that home as well. It supports early use of compression for subclinical lymphedema. Okay. Oh, okay. So I love this question. It's my understanding that the devices themselves aren't very expensive. I want to say we've had ours since June of 2020, and we actually have 3 of them. We have one in our rehab department, surgical oncology has one, and plastic surgery. So I think the cost of the device was quite nominal. I want to say $700. But the problem is that SOZO, all 3 of our devices communicate with each other on a cloud, and you actually have to buy a monthly subscription to pay for that cloud that all of that data is stored on. And I think that that monthly subscription is a deterrent to a lot of people. But it would be interesting if you wanted to consider SOZO in your clinic. It would be interesting to see what information they would supply you with. Oh, how much pressure? Okay, this is a great question. The standard is 20 to 30 mmHg, so millimeters of mercury pressure. And that's what's considered medical grade compression, so 20 to 30 mmHg. I do have some patients, and probably Amy does too, like if they have cording or they have pretty severe radiation, the compression band tends to be really tight in the axilla. And so if that's the case, then I'll downgrade them to like a 15 to 20 mmHg compression sleeve. But the standard is that it's a 20 to 30 mmHg compression. Good question. I should have included that. All right. So at OHSU, until fairly recently, we were really she's moved on. She left, but we actually had a supromicrovascular plastic surgeon. And the whole idea was that as much as we want conservative treatment to be effective for lymphedema, it's not always effective in some cases. And lymphedema, even though despite our best efforts, lymphedema continues to progress despite what we're doing. And so there is now an international appreciation for surgical intervention of lymphedema. And one of the first line defense of intervention is immediate lymphatic reconstruction. So this is where at the time of mastectomy, of axillary lymph node dissection, or lumpectomy with axillary lymph node dissection, at that time, the plastic surgeon is in the room. The supromicrovascular plastic surgeon is in the operating room, and she will actually do, or he or she will actually do a lymphovenous bypass where they take the distal end of the lymphatic vessel and they reconnect it to a vein in near the distal end that was cut of the lymphatic vessel at the time of axillary lymph node dissection. So what's really interesting is that, and then this was from a study at Beth Israel Deaconess in Boston, at Harvard Medical School. They thought that lymphedema occurs in 40% of women who have axillary lymph node dissection and radiation without immediate lymphatic reconstruction, but they feel like they can reduce that risk down to 12%. If that person at the time of axillary lymph node dissection has immediate lymphatic reconstruction where they connect the distal end of the cut lymph vessel to the nearest vein. And I'll talk more about a lymphovenous bypass in just a minute. But this is done at the time of surgery to reduce the edema occurring. Regardless, we would always do, even with these people having a 12% risk, we're still going to initiate our breast cancer related lymphedema surveillance for prehabilitation, so prior to surgery. We would still recommend early compression if they were having subjective symptoms, or if their LDEX score or bioimpedance increased of more than 6.5, and we would still do continuous education with them. And we might even do some manual lymph drainage to enforce the patency of that vessel. All right. So here's lymphovenous bypass in more detail. So typically when we refer to lymphovenous bypass, it's done showing subclinical signs of lymphedema. So when their LDEX score increases, when they are shown to have, when the endosine green studies show that there's dermal backflow, someone could be a candidate for a lymphovenous bypass. And so that is where they reroute that lymphatic backflow directly into a vein. Remember that all of the lymphatic collectors actually re-enter cardiac circulation at the venous angle of the jugular and the subclavian vein. Right at that venous angle, all lymphatic collectors re-enter cardiac circulation. So when we take a distal lymphatic vessel like in the arm, and we reconnect it to a vein, we're just putting it in the venous system sooner, so it bypasses the blocked area. It's a very, very small incision. In fact, our physician at OHSU, she told me the microscope alone to do these surgeries was $1 million. It was really hard to come by. It actually took her 2 years to get the microscope. Whoops. So it's very, very small. Our surgeon told me that her sutures, what she would use to connect the lymph vessel to the vein was the size of a hair. The sutures were the same diameter as a hair. The good thing is that it's a really small incision. There's minimal blood loss. Often in one incision, they can make multiple anastomosis. After surgery, we usually tell people no shoulder elevation, no flexion above 90 degrees for the first week. Oftentimes they're bandaged with compression bandaging in the PACU or the outpatient center. And then they're transitioned to their typical compression garments at about 3 weeks. We can do manual drainage as normal. They can do light exercise and normal activity within 1 week, but they're cautioned to avoid vigorous exercise for 4 weeks. Oh, okay. All right. So another option is a transfer. And most often, so vascularized lymph nodes, they're taking the lymph node itself with its blood supply, and they're transplanting from one area of the body to the axilla. I've also seen sorry. Are we good? I'm going to keep going. All right. So this is a little bit more invasive than a lymphovenous bypass. Often the most common donor site is the omentum. If you can find a really good surgeon who has very clean margins, I think the physician handpicked her general surgeon because she knew he would have a good specimen. So they take a lymph node from the omentum with its arterial and venous supply, and then they transplant it in the axilla or where there's known to be dermal backflow, in hopes that the vascularization will anastomose or connect or regenerate. They don't always connect the lymph vessels, so it's not a lymphovenous bypass. There's no connection, but it's hoped that lymphangiogenesis occurs when they place the lymph node in the deficient area. The problem is that we have this this practice in medicine of doing no harm, right? So we don't want to take lymph nodes from the groin to treat the axilla. We don't always want to take lymph nodes from the neck to treat the axilla. We don't want to cause secondary lymphedema by trying to treat lymphedema. So it's not always that common of a practice, but we have seen it. I think that some clinics also practice a cocktail approach, where they might do a vascularized lymph node transplant, a lymphovenous bypass, and maybe they would do some suction-assisted lipectomy of the fibrotic tissue. No matter what, these people probably, if they do elect to have the vascularized lymph node transplant, it doesn't mean that they won't stop wearing compression. But the idea is to stop the progression of lymphedema into the next several stages where there is no surgical intervention when the vessels are at the third stage of lymphedema when the vessels are in patent. There's nothing that can be done at that point. So are done when in early stages of lymphedema. They typically have the best results. Again, but there's a lot more complications with a vascularized lymph node transplant. People typically stay in the hospital. They're monitored for infections. They don't use compression right away. They have to avoid limb dependency. And then after they're in the hospital, they might even be in a splint. For example, if the vascularized lymph node transplant was close to the wrist, they might even be in a splint for a week. We don't typically see them until 3 weeks after surgery, and that we would be doing manual lymph drainage towards the vascularized lymph node, hoping that lymphangiogenesis would occur. And then we would also at 3 weeks start compression. They might have some range of motion, so they wouldn't maybe go to the end range for wrist extension or wrist flexion if that's where the location of the vascularized lymph node transplant was. We would only for the first 3 to 4 weeks recommend light exercise, and they would abstain from resistive or vigorous exercise until after 6 weeks. So no lifting more than 10 pounds after 6 weeks. Some clinics have very specific compression weaning protocols. After these procedures, they might say at 3 months, go the morning without wearing compression and see what happens. If you can detect that the swelling is persistent, then put the sleeve back on. So maybe for 1 week you wouldn't wear compression just in the morning, and then by the next week you wouldn't wear your compression for 1 day and in the morning. So they have very specific protocols for weaning from compression. Our physician felt like compression was necessary no matter what. And I've heard from other physicians, maybe you would wear compression during normal everyday life, but if you were going to a special event, you could probably go without wearing the compression. So there doesn't seem to be a consensus on compression weaning protocols after these surgical interventions. All right. So I'm going to take another tangent, but I'm going to draw it all back together. There are emerging studies that there is a direct relationship between BMI and lymphedema. And that these are relationship is bidirectional. So maybe lymphedema can cause obesity, and maybe obesity can cause lymphedema. The thing is that obesity and lipedema, people with obesity and lipedema are often mistaken for having lymphedema. And for some reason, we get a lot of referrals for people with obesity and lipedema, but our complete decongestive therapy isn't always effective. We can't use manual lymph drainage to remove adipose tissue. So they're often mistaken. So there was a study that was published in 2021 in the Journal of Obesity. It was aimed to distinguish the difference between lower extremity lymphedema, obesity, and lipedema using lymphoscintigraphy. So the ICG, the indocyanine green studies, that biofluorescent that they were using to track with the light. So they really wanted to delineate the difference between obesity, lymphedema, and lipedema. And they thought that if we delineated those diagnoses, it would change how we would look at management. So they had 98 patients who met the inclusion criteria. 46 had abnormal lymphatic function that was predicted by their BMI. They found that people with a BMI of 40, they felt like there was a 0% risk. So anyone with 40 or less, BMI of 40 or less, zero lymphedema detected. But when they got from 40 to 49, of those 98 patients, 17% had lymphedema detected. Then 50 to 59 BMI, 63% had lymphatic dysfunction. 60 to 69 BMI, 86% had lymphatic dysfunction in their legs. 70 to 79 BMI, 91% had lymphatic dysfunction. And then when we get to a BMI over 80, 100% of those patients had impaired lymphatic functioning. So we know there is a direct relationship between BMI and risk of lymphedema. So of those 98 patients, they found that 17 had lipedema. So they had irregular adipose deposition in their lower extremities. Only 2 of those people with lipedema, which is a fat dystrophy problem, only 2 of them actually had lymphedema on imaging. So they're saying that standard isn't effective with lipedema because they don't have lymphatic dysfunction. Again, so when we see patients that are referred to us for lymphedema of their legs and they have a BMI over 40, we usually say and caution these patients, you know what? Weight management is your first line of defense. And if the weight continues to be an issue, you have a higher risk of irreversible which then causes a higher risk of infections like cellulitis. We tell patients that weight management is the primary management of lymphedema. And a lot of times patients who did reduce their weight, oftentimes their lymphatic was if it was caught in time. Conservative management techniques such as compression garments and pneumatic compression pumps are minimally effective because the adipose tissue is compressing the lymphatic vessels. The lymphatic vessels are not able to contract or able to propagate the lymph tissue when they are compressed with adipose tissue. So weight management is the primary focus in people with lymphedema, and their BMI is over 40. And saying this again, going back to who is at a higher risk of getting lymphedema, with axillary lymph node dissection, radiation, a taxane-based chemo, and a BMI over 30. So if we see these patients that are undergoing breast cancer surveillance in our department and they have a high BMI, we can go back to this study and we think that part of the standard of care for these people undergoing breast cancer treatment should be a dietitian and nutritional consult. They should automatically be a part of the team to prevent breast cancer related lymphedema. All right. Any questions for me? This is a lot of information. I feel like, yeah, so if you think of something later, that's okay. So Connie, are we ready to transition then to Amy's part?
Yeah, for sure. If you want to
I'm
unshare.
gonna stop screen sharing then.
Okay.
So do you see Amy's?
I do. I just wonder, Ton, do you need to take the picture now?
Okay, thank you, Connie. I'm done for capture already. Everybody are in my file. Yeah, thank you very much.
Okay, perfect.
Okay, may I ask?
We switch.
Oh, Dr. Sushila has.
So in conclusion means that immediately after it doesn't matter sentinel surgery or axillary lymph node surgery, which are dissection, we should use compressive stocking immediately. Is that right?
So I love this question. Fantastic question. So this, yeah, this is a hard question to answer. Our practice at OHSU is that we have them order the compression, so that they have it and they can use it immediately if symptoms occur. Because of those highest risk group, only 25% of them will actually get lymphedema. So compression would be unnecessary for 75% of them. But we want them to have it for immediate use when the very first subclinical symptom shows up. Do you feel like that's a sufficient answer? It's a complicated question because I think every facility has a different practice. So, I will move on to more of the practical application of what we just talked about.
So I was going to cover, Sarah covered surgeries, research. So I was looking at, since the concept I think is to be developing a center of excellence at your facility, what we do are evaluations and kind of what we're looking through. So I kind of took what we have. So these were, Sarah touched base on just prevention, survivorship. So these are ultimately our rehabilitation goals, whether it's prehab to talk to people about their risks ahead of time. Are we going to be seeing them throughout their treatment? How long afterwards? So I just kind of put what goals can be for working with them. And then also the palliative part, we see patients of all spectrums of care. The next slide is our evaluation. So typically what we'll have for a common diagnosis coming in to see us, again, either in prehab or during their treatment, is chest pain, breast pain, a lot of breast edema. I know we've been talking about lymphedema in the arm, but a lot of times with lumpectomies, I think probably a common side effect is breast edema, just from the surgery. That happens when you just remove the lumpectomy and the body has to fill in the space. And so they are left with a lot of breast edema. And so we talk about compression bras to help with breast edema. A lot of times we have abnormal posture coming in. If you have, a unilateral or bilateral mastectomy, it can change the position of the shoulder, their neck. Sometimes people are already coming in with rotator cuff injuries, neck pain, back pain ahead of time. So it's always important to see what was their baseline before their diagnosis and what are we dealing with? Did they have frozen shoulder ahead of time, or rotator cuff surgeries? We also have they'll come to us with a lymphedema diagnosis, shoulder pain, incisional pain, wherever the incisions were, the cording, which we'll address in a few slides, and people end up having pain on their ribs, their trunk, and back in the shoulder. And again, it's from a lot of times from the radiation of the surgery that pulls our shoulder forward and pain in the back. And so I usually address that from the get-go because people are like, oh my gosh, that explains why my neck is sore or why my mid-back is sore. And then these are just the types of surgeries that we usually keep in our evaluation shell. So the way we have it is we have drop-down menus. So then we can kind of plug it from the patient's chart. And so these are all just the surgeries that Sarah went over earlier. And again, what we want to find out from a prehab appointment is, are they having pre-op chemotherapy? Are they going to be, when are they going to be having chemo? At what point, if they're going to have it? Did they have radiation already? Is radiation coming? What kind of surgery are they going to be having? Or what surgery did they have? And so our job is to kind of figure all that out ahead of time. And then we talk to them about physical therapy. A lot of times we use acupuncturist at OHSU. And how we can use that afterwards. And so we're also looking at the number of weeks they're coming to see us post-op, how many number of lymph nodes were removed. And again, all the things that Sarah said pre-operatively is what we want to be sure that we document in our chart. So what we do is we usually find in the medical note the background of what they had, and we like to just kind of copy and paste so every therapist has a good sense of where did they start treatment, where are they at, and so it's easy to kind of take that from note to note, so you can always look back, especially if you haven't seen somebody in 3 months and you have it in their note. You can see, oh, back in April they had this surgery or they finished their radiation at this point. So it's just nice to kind of have that to refer back to. And then we always also like to have in our treatment note, like any precautions or special medical issues that may have. Do they have osteoporosis? Do we need to be careful with, doing any kind of joint manipulation or shoulder range of motion or anything else? We like to put that in the top of the note. So when you go and look, you can see anything that you might have to be concerned with. So again, the BMI, again, that's a huge thing. So usually in the evaluation, or at least some point early on, we talk about the importance of exercise. If BMI is high, we'll talk about why it's important to bring that down. And again, for all those same reasons that Sarah already spoke about, why we want to talk about exercise and BMI, we want to find out what their past level of exercise used to be. How active were they prior to diagnosis? Because a lot of times patients are coming in, they're having chemo-related fatigue, and they were a mountain climber, and they want to return back to doing that, or were they always sedentary and had a computer job? So it's nice to know, are you trying to talk to somebody about exercise that's been doing it for their entire life, or are you trying to talk to somebody about exercise who is just getting into it, and they're getting into it dealing with chemo fatigue and all these other range of motion impairments or cardiovascular issues that they may have from their chemo. So it's always good to kind of have that kind of baseline of where people are when they're coming in. So what I brought, so I'm not sure, we'll kind of show with Sarah. So you let me know if you can see it or not see it. So this is kind of what we talk about with what we measure for the circumference. Yeah. So again, this is what we use. And so we like to keep it standardized. So all of our therapists will have the same measurements in the note. So I just kind of put it there. So we just use just a regular tape measure. And then when you use the third, let's see, PIP joint. And then we'll do the MCP here. That's the next one. And then we go from the wrist, take your measurement, and then from the wrist, you'll go up 10 centimeters, you'll take that measurement. You'll go up 15 centimeters, take that measurement, and then we go up to the cubital crease here, take that measurement, and then we'll go up 10 centimeters from here, and then take that measurement, and then we'll go up 20 centimeters from there. Sometimes if somebody comes in and they have significant swelling, maybe somewhere other than those measurements, then I'll usually take the measurement at the largest part. And then I'll just document that in the note in the table if something doesn't quite match any of those numbers. But pretty much for the most part, it's really good to keep things standardized so everybody's measuring the exact same way. So if I were to see a patient of Sarah's, I know exactly, okay, this is what we measured. And then if I see like, oh my gosh, we're much bigger here or much smaller there, then we know that it wasn't because I maybe measured just randomly at this spot or that spot. So it's really good just to kind of, for standardized of care, to kind of be the same when you measure for circumference. But again, it's really quick and easy to do. So every time, I usually do it pretty much almost all the time because it takes me literally less than a minute. However, the Sozo machine that we have athletic trainers. But now that the system is so set up so quickly that sometimes that just takes less than 5 minutes to take them to the Sozo machine. They take their shoes and socks off, have to take rings off, and they just stand on the scale, and we can get a really quick measurement that way. But this way, usually when we bring a patient back, it's pretty quick to do this. So either that, and the SOZO, you don't have to do it all the time, but we do want to do it at that 3, 6, 9, and 12-month marks. So as far as range of motion, so we want to look at how, well, first of all, when a patient comes in, I want to be sure I look at their, and let me know if we can stand up or if you can't see me or the chat. I don't know if we can pull the chat.
I'm gonna pull the chat up. Let me see if I make it big.
Yeah. Okay.
Okay.
So we want to see what their range of motion is. So for flexion, we just have them bring their arms up this way. And then we can kind of notice if they have any limitations. Let's say this was the affected side. Can they not reach up all the way? And then we would take a measurement, and then we typically do abduction, and then we'll do extension, and then kind of external rotation. And then we usually like to see how far can they reach behind their head here? Can they reach behind their back here? And then we usually take measurements of both sides. And so it might be just a quick eyeball, can they get here globally? And then if there's big deficits, then we'll take the goniometer and actually take measurements. We'll manual muscle test, and it's usually just a quick screen for like flexion, abduction, elbow flexion and extension, just to see if there's any weakness in either of the limbs. We usually talk about pain ahead of time, but usually we have the conversation of lymphedema. And usually with lymphedema, it's more of a fullness, a heaviness in the arm. Typically, people don't really report pain. So I like to talk to them about the difference. Are you having pain, like electricity pain? Are you having numbness, weakness in the arm? What describe the pain? And so then you can tell, are they having something, maybe during surgery, there was a nerve that was cut or injured just from the positioning of being on the table. So maybe they're actually having something cervical from the weakness, or something else other than that was affected from the breast surgery or the radiation. So it's really good to kind of get a good sense of what kind of pain that they're having. And then I usually like to look at their posture when they come into the room. And a lot of times, are they really guarding their arm? Are they keeping it in here? What is their sitting posture? Do they have good upright posture? So usually on the posture form that we use, I put on here what we usually have, whether it's good, mild, moderate, severely slouched, how forward are their head and shoulders. And for the most part, I usually always have the conversation before they leave for the first time with me to talk about posture, because we can do all the range of motion exercises, manual drainage, but if we don't address what somebody's posture is during their day, are they working at their computer all day and then they have this radiated tissue and tightness, and they're keeping their arms forward? Do they have hobbies? Are they cyclists? Are they doing anything that's really forward? And I like to tell them that this, monitoring your posture, you might have been able to get away with not really having good posture prior to these kinds of surgeries. But when you have the surgery and you have radiation, the skin and the tissue, everything is different. We can't undo what happened to the radiated skin. And that is something that usually can last long term. It's not that you won't keep your range of motion, but when you lift your arm up, it might just always feel tight and leathery. And it just might kind of be that way for 3-5 years, maybe long term. So I really want to always address the importance of posture kind of forever going forward when I see them kind of that first time. We look at, is there any muscle atrophy anywhere in the arm or the shoulder? And then another part that we have in our evaluation is what their hand dominance is. So same thing. This is, again, is part of our evaluation shell, so it has a drop-down menu, so it makes documentation really easy when you can go through. So we're kind of, so usually it's through the back, to the breast, maybe down to the side here. And sometimes you can actually get it, you can see the radiated field back here. And so a lot of times they'll have their tattoos. And so there'll be, 3 or 4 tattoos, some vicinity. And so I usually like to tell people, that whole area, wherever it is that you had your radiation was affected. It's just not your skin, your tissue, your muscles. Your ribs are here, your lungs are here. Was it on the left side where your heart is? Your scapula is back here. That whole area was radiated and it's different. So you want to be mindful going forward of, are you getting more prone to having coughs, getting colds just from the lungs being affected? And so we want to look at the whole skin in the front here and the back. Is it sensitive to touch? And so I kind of put here how we classify it as either normal, mild, moderate, or severely decreased, depending on when they come in.
That's the question.
Oh, go ahead. Yes, and those are coming up. Yep. I use the ones that we most commonly use for the outcome measures. We use the lymphedema impact scale pretty much with all of the patients that we know are coming in with the lymphedema diagnosis. Sometimes our schedulers will give out maybe the dash, a quick dash, if they're having neck and back, respiratory, or the patient-specific functional scale. So those are kind of the main outcome measures that we use, but we usually like to get at least one of those, if not 2 of those in the evaluation in the get-go. And we have flow sheets, so we can easily track those and put those in, and they auto-populate into our treatment notes. And so then again, we're looking at the incision sensitivity, where their drain site is, and frequently people, I think, don't realize the trauma that the drains have, and they kind of are right in where the ribs are. And I usually just kind of describe it to people, there's not a lot of tissue with the ribs. There's a lot of already connective tissue there. And so when you put a drain in there and you have a drain in for 2 to 3 weeks, and you're moving around, and even though the drain, isn't coming out, it creates a lot of scar tissue there. So I do a lot of manual work on the drain sites. And it just kind of is validating to let people know that that's where your drain is, and it's right where your ribs are. And most patients, they can't even tell it's there or see it's there. So checking on the drain site is important so that you can document, how that is mild, moderate, or severe. And then again, going back, we'll go into the cording. Looking in the axilla, what do we see here? Do we see single strand cords, double, triple, Mondor's cording, which is down here under the breast? What are you seeing? And then we usually like to, again, document that. And we usually do this the first day. So we're, again, taking the measurements, looking at the quality of the skin, what is their range of motion. And then these are just some of the other more skin tissue things that we're looking for. Is there a stemmer sign? Is there pitting edema? Is there pigmentation, fibrotic tissue, fistulas, redness, hyperkeratosis, varicosities, with the breast edema? How much is there, little, medium, moderate? So those are kind of, again, on our whole list. So it's easy for us just to kind of check and either minus or a plus on all. So we pretty much go through all of this, and it populates a minus or a plus on all of these. So again, we can kind of just keep auto populating it with all of our treatment notes. It's a long list, but it's quick to go through when you just put a plus and a minus. These are the outcome measures that we use mostly. Again, I think pretty much, I would say 90% get the lymphedema life impact scale. And again, and usually they get at OHSU every 6th visit, they will get a new outcome measure. So we're constantly monitoring progress on any of these scales. So it's nice to have it there, auto-populate in your flow sheet, and then you can put the next one in, and then you can actually compare. And I would say pretty much by the 6th visit, the lymphedema life impact scale is significantly improved from the first time we meet with them. Sometimes if it's a patient-specific functional scale and they want to get better at mountain biking or something, that it might not see as much of an impact in those first 6 sessions, that maybe 12 sessions they're getting back to what they used to do. So then we have in our treatment part of our note, again, all of this again is a drop-down menu, so it's really quick to do documentation. We cover the lymphedema education. We actually have a smart phrase that we print out for them that I think we sent to you. So then it shows all of the pictures of the state. Well, it talks about what lymphedema is, what happens with radiation and why that's so important. And then it shows patients the stages from 0, 1, 2, 3. So I usually like to touch base and educate patients, even if they have a low risk or a high risk of what lymphedema is, because even if your risk is low, 5 years from now, if all of a sudden you're having some symptoms in your arm, we want them just to at least have had that conversation of what to look for. Because sometimes down the road, if you're having symptoms in your arm, maybe it's a new metastases. Is it something else that has reoccurred somewhere else? And is that why your arm is swollen? And so the discussion might be quick or short, or it might be long depending on their risk. But I always like to print out that form. And I usually tell patients, take it home, read it over after I discuss what to be looking about. Is usually describe it as it's like a your sink, and your sponge gets full of water. Your sponge doesn't, but it gets heavy. And so when you start to feel that heaviness, it's when that buildup is happening. And then usually later on is when they see my ring is tight, my watch is tight, my sleeve is tight. So it's not always the first sign. And so then they kind of are like, oh, okay, that makes sense. We talk about fatigue management. Just because fatigue is so common with chemotherapy, it's a common side effect of radiation. It's not only a common side effect of radiation, but they're going to appointments 5 days a week for 4 to 5 to 6 weeks, and that's just draining in itself. You got to come, you got to park, you got to go, and then you got to come back, take care of your children or whatever it may be, and that just kind of just snowballs. I usually like to tell patients, you just want to try to maintain as much normal routine as you can. We encourage 30 minutes of walking every day, but broken up into minutes, maybe 5 minutes here, 5 minutes there. So you want to do something every day. Because if you do too much and the next day you can't do anything, then that snowballs into 2 days of not doing anything. You're already deconditioned. You're just going to get that much more deconditioned. So it's a different kind of deconditioning versus what they used to have. Like if you just worked out too much, or you worked out too much, or you worked too much, or whatever it may be, that we want to be sure they have enough gas in the tank, that every day they wake up feeling like their gas tank is full and they have enough gas to get through the tank by the end of the day, that they don't go through their gas tank by noon and then they're out for the count for the rest of the day. So I really try to on chores and doing these things, but maybe you need to break them up into little pieces, and maybe you do laundry today, but you don't do laundry and cook a big meal or whatever that may be. So we have information on sleep management, a lot of the medications that they take, stress, anxiety, people don't sleep well, and then that just boils into the fatigue point. A side effect of chemo is peripheral neuropathy. So I have one of the slides coming up, what we talk about with managing peripheral neuropathy, because they can't, their feet and hands, but mostly more so in their feet, get really tight and they can't feel much. They start to walk more kind of on their toes, and so they don't realize like how tight their calf gets. So imagine that you're walking on little pillows or you're walking on a surface, and tightness, if this was my foot pulling up on my calf, is going to make my calf complex really tight. So we really want patients to stretch their calves daily, regularly, kind of roll on balls. If this was my toes, stretching their toes, because the fascia in the feet get tight. We usually educate them on using like mineral ice or something cooling to desensitize the bottom of their feet, which helps, and wearing compression socks, because the more they can desensitize those nerves, that we can't take away most likely the sensation of the neuropathy, but it can help just with managing that really intense, sharp, needly feeling. And we also talk about balance exercises and the importance of fall risks and not having that. Energy conservation, that pretty much goes kind of with the fatigue and the sleep management. The edema reduction sequence is one of the exercises that we sent over, and I'll go over that in just a little bit. And then we talk about manual lymph drainage. I didn't really go into any of that much today because that's a whole nother section on just lymphedema itself and how you do that. And in the United States, I'm not sure about other parts of the world, there's lots of different lymphedema certifying bodies. And so depending on who you got certified with, your manual lymph drainage techniques might be a little bit different. So it's hard to say. But usually at the end of the session, we have all of these printed out for them. And then usually just to kind of make our documentation quicker is we kind of have these as smart phrases. So then we always want to be sure we cover that we talked about lymphedema, what it is, what is your risk, the importance of exercise. And then if they are a high risk patient who needs compression, then that's when we give them the information to go to we have 2 places in Portland that we use that do the fitting for the compression garments. And then we usually send the doctors a note, and we have a smart phrase that has exactly what the doctor has to say, and they put that in the prescription. And then the doctor sends over the prescription to either of these 2 places, and then they get their sleeves fitted. And whether insurance covers it, we don't ever really know. It seems like Medicare and insurances yearly are changing things, but that's kind of what we do because we don't provide garments at OHSU, and so that's why we have a garment centers that we send our patients to for the education. These are usually the goals that most patients that we want them to look at 8 to 12 weeks down the road. We want to talk to them about how they can manage their lymphedema at home with the home manual lymph drainage program. Are they watching their skin? Are they wearing their sleeves? Are they using their pump? So we want them to be independent with all these practices at home. We usually discuss pain at some point in the first evaluation, and so we want to try to get their pain down to 2 or under. We always want to be sure they're wearing their compression. Again, most important is exercise and compression. If anything you take home from this lecture is exercise and compression. And then again, the manual lymph drainage, but those are the 2 key things long term. We want to, if their goal is range of motion, strength, and whatever their functional goal may be, is it yoga, is it biking, is it golfing, is it just working or playing with my children or whatever it may be. So those are usually the goals that we have. And then our plan of care as therapists, we talk about the TheraX, the exercise again that we'll talk about to address posture or range of motion deficits. We usually do a lot of manual lymph drainage. I think that's pretty much most of what we do in our session. And then compression education, we want to be sure they have a home program, the skin care, and then teaching them. So that's usually our plan of care for almost, I would say, every patient, whether it's all of those or some of those. And again, that goes in our note. Some of these things that we touched base on is the effects of reconstruction. Again, depending on the surgeries that Sarah went over, sometimes we see, I think more so with lumpectomies, is seromas. And so sometimes depending on how large the seroma is, they might have to drain it. And for myself, the more trauma to the tissue in the breast or wherever their seroma is, their risk for swelling in that area or maybe into the arm, I have found has been increased because there's just all that extra fluid there and your body is trying to get rid of that fluid, and sometimes they have to go in and surgically drain it, and so that's just more trauma to the tissue. And so I see that those patients tend to have a little bit more issues maybe with their skin integrity or just range of motion or tightness. Again, just because of the surgery here, and I usually tell patients the tissue here gets really tight. Your chest muscles attach here, your arm muscles attach here, your attach here. And so radiated skin feels very leathery. It feels like saran wrap. It feels like, so again, want to push the shoulder forward, and sometimes people get rotator cuff or frozen shoulder or any of those things. And again, the chest pain, sometimes they get a lot of sternum pain. If they have expanders in, they get a lot of rib pain right where the expander sits. They are often asked, why do they have rib pain here? And again, why do they have specifically a lot of upper trap pain? Because when you have an expander in or not, or just these surgeries and they're pulling your shoulder forward, it pulls it up here. So then people are constantly trying to go after tightness in their upper trap. And so when my shoulder sits down more, then it relaxes my upper trap. So those are issues with some of the reconstruction surgeries. Again, and a lot of times they can't sleep on their side. They have their back, and they might not have ever been back sleepers. And then just the pressure of the expanders or whatever it may be, sometimes it's just hard to sleep. Sometimes it's hard to because the diaphragm is there. And if the diaphragm was affected, the nerves to the diaphragm during surgery, they just might have issues breathing. So those are some of the effects that we see in physical therapy after reconstruction. Again, the effects of radiation, kind of everything that we've already touched base on. Some of them are temporary. That's why we like to see people sometimes during radiation, usually to a point where if their skin starts to break down and it gets raw and too irritated, we might not be able to see them during that time. But a lot of times we have patients who we have to get their range of motion to here or wherever it may be so they can get in the machine. And so if they can't get in the machine, then that will postpone their treatment, which then might postpone everything. And then again, the swelling, pain, the redness, and just that really tight tissue. It can be temporary, but then I've seen people long term, again, not necessarily that it keeps, they have decreased range of motion, but they just say it just feels different. And I usually tell people the first year, it's kind of like a roller coaster that some days you feel like you're great and you come in and you're like, I feel good. And then the next day you come in and you're like, I don't know I didn't do anything different. And I think the first year of radiation is very rocky. And after each subsequent year, the kind of the peaks and valleys get longer or wider. But for whatever reason, radiation, a couple years later, it might just be like, I have no idea why I'm really sore today. And that's just, I think, what happens with radiation. Things are just different now. And I find that when patients kind of realize that, then they kind of don't get so scared. Because when you have cancer, then all of a sudden every ache, pain, is that a lump? Oh my gosh, what is this? What is that? And they automatically go to, do I have cancer again? Do I have cancer again? Do I have cancer again? So I try to give them any possible scenario that could happen down the road. And then I find that patients really appreciate having had that, at least that conversation. And they're like, oh, that's right. You said it might ebb and flow, or it might be whatever it is. So with the surgical tissue, again, just things that why this happens. So I just kind of put that slide in there we see it mostly with the radiation and axillary lymph node, but the sentinel lymph node, again, is probably more breast swelling. Effects of chemotherapy, immunotherapy. Another thing that I usually like to ask patients about is chemo brain or chemo fog, especially if somebody has a computer job or any kind of job, really. Are you having a hard time thinking? Are you having a hard time finding your words, processing your words? And at OHSU, we have speech therapy that can address any cognitive issues that somebody may have with chemotherapy. And usually our note auto-populates their blood work. So usually before I see a patient, I always check what their blood values are, specifically the hemoglobin. We have a list of the numbers of what's appropriate for exercise. So if they're coming to me and their hemoglobin is a 6, I know most likely they're not going to feel great. I'm not going to be able to do a lot of exercise with them, but I want to educate them on, what the effects of anemia are and how they should kind of pay attention themselves to their blood values. Because sometimes the doctors aren't super specific on, oh, you're that low, you better not go for a walk. And a lot of patients come in, they want to feel better, and they're like, gosh, I can't even walk my dog today. And I look up their values and it's like, oh my gosh, well, your hemoglobin is 8. It's no wonder that you're having a hard time walking. Osteoporosis, with the hormone therapy that most patients are on, usually talk about the importance of strength training, and weight bearing exercises, because it's a very common side effect. Osteopenia, most of our patients get bone density baseline measurements. So then I usually like to ask them, do they know, are they osteopenic? Where are they? And then again, reiterate why strength training is so important to help. And why depending tolerating, and they're not getting fuel, so they are nauseous or vomiting. What is their appetite like? What are they eating? And again, with chemo, a common side effect are skin and nail changes, and sometimes they have to deal with blistering fingers or feet. So this is the peripheral neuropathy, which I already touched base on. This is what we print out for patients, and that's what we kind of go over. And then also talking about good supportive shoes that will also help with the neuropathy. Sarah went over all what breast cancer related lymphedema is, and the complications of it. So I put on here what complete decongestive therapy is. When you look at it all together, it's the manual lymph drainage that the patient will do or that we will do. It's compression, exercise, and skincare, and then basically educating the patient in all of those. So when you have a complete decongestive therapy program, you're covering all of those. So that's what we do. And then I just put kind of what are the absolute contraindications to that complete decongestive therapy. So anybody who has an acute infection, you don't want to do manual lymph drainage, or they should be getting to their doctor, whether you call them then and you get them in, or you tell them to go to urgent care, or however it works in Thailand. Renal failure, cardiac edema, and acute deep vein thrombosis and acute bronchitis is typically times we don't. Relative, it just kind of depends. With malignancies, sometimes it's palliative, and you are just trying to help the patient feel better, get their range of motion so they can put their clothes on or whatever it may be. So I just kind of put what the relative contraindications are: bronchial asthma, history of hypertension, and congestive heart failure. So it's always just good to know those things ahead of time. And then these are just the contraindications for manual lymph drainage. So again, the absolute is a deep vein thrombosis, and then those indications for compression, cardiac edema, arterial disease, spasticity, acute infections, stage 2 complex regional pain syndrome. And then those are just the relative contraindications: hypertension, cardiac arrhythmia, paralysis, diabetes, malignant lymphedema, and then again, the chronic pain syndrome. So with the axillary web syndrome, I'm going to have Sarah just lie down here. So let's see. Maybe scoot down. Okay. So a lot of times, we'll have, when the patient comes in, we'll usually address in sitting and standing their clavicle. What are their shoulders doing? What is their rib cage doing? What is their back doing? And again, we would have already gone through all the range of motion things. So somebody comes in and they tell me they have cording or webbing or whatever it may be. And sometimes you can see it before they lay down. And so some of the techniques that we can do is we want to kind of check their shoulder range of motion, inflection and rotation, abduction. So you kind of want to see where the cord is. And a lot of times what I do is I'll scapula in this position. And this is where you can really see people get really tight, is right through here. And usually the drainage, the cord might come from here. It might go all the way down to their wrist, and it looks like a guitar string or a violin string. It can come anywhere through here to here. So a lot of times I'll kind of look at what their scapula is doing, what their ribs are doing. But when the cord is here, you kind of want to, if the cord was like this, what we typically do is you work and we're kind of doing, I put on one of the slides there is like, you're pinching an inch, you're kind of pushing the cord in a C pattern and an S pattern. You might be doing some kind of tissue stretching. Sometimes they release when you're doing that. Sometimes you can hear it snap. It's not really loud, but sometimes patients usually can feel it. And so usually what I do is just kind of get them in a comfortable, I would probably be over here, but just so you can see. And then just kind of work the cord, however far it may go down. And then kind of always go back and kind of assess what this is doing. I'll also get them in sideline. So a lot of times from here, usually you can kind of see in the axilla here. So I usually will do a lot of this kind of motion, kind of getting the cord here, depending on what's happening here. I find that a lot of the restriction is here and down through here. So if I can kind of help get this moving, I find then the cord gets softer, and then I might put them back down into supine, maybe back in sideline, just to kind of depend. I usually always like to see what their shoulder blade is doing. So a lot of times I'll kind of do some shoulder blade range of motion, because this is a common area where they get really tight, is all through here. And if we don't address the restrictions on the backside, and we only focus on the front, we're missing a big piece of the puzzle. And I do a lot of work on the upper trap up here. So I'm kind of working the whole area here, whether they have cording or not. It just might be thick radiated tissue. And again, if that radiated field came all the way down here, you really want to work on all of that tissue all around here. Again, because things are happening in the front. So a lot of the times when I'm tight and I've got expanders or surgery and it pulls me here, I got to get this all released so I can get my full range of motion, and then I can do my exercises. So that's just kind of a quick of what so a lot of, it's going to feel discomfort. So exercises is they would take and stay there and then bring your arms back down to your legs and then go again. So you might do that 10 times. Then they do snow angel arms, where their arms are down at their side, palms up, and then they would bring their arms out to the side. And they would pretty much on the table be able to do both sides. They can bring their arms behind their head. This is vacation pose. To add more of a stretch, stretch, if you have them bring their knees over to the side, that's going to get all of this right here and up through there. If they want to get more of a stretch, they can take this hand and reach it over here. So I just let them dictate and guide wherever they want to go, where they feel the most stretch, because it's going to be different for everybody. So those are just some of the ones laying down on the table, bed, mat, wherever it may be. I usually tell a patient to do all this throughout your day. They'll use the other stretches on here are up a wall, to go up a wall, straight up the wall, up the side wall. Do this stuff when you're just standing, when you're at work or when you're at home. You can build all this in. But stretching is so important. And again, watching their shoulders, if they are trying to stretch like this, I'm not going to get very far. But if I bring my shoulders down and back, I can go up higher. And that's all I did, is I got my shoulders out of the way. Again, lots of trauma and tightness in the front. We want to be sure they get their full range of motion through there. Some of the exercises, go ahead, strength ones that we do. Go ahead and see them. And then step that way. And just hold it. So again, my shoulders are down and back, I'm tight, and I'm just going to pull. And it's a pretty common exercise to give for a row to strengthen back here, to again help their shoulders back. So that might be an exercise we give. Sometimes we'll kind of give a shoulder extension where they're nice and tall and they'll pull their band down this way. So that would be a quick like resistance band strength exercise. But again, the ones that we send you are all the ones that we print out for patients. The breast surgery exercise is less than 2 weeks. Let's say they had a surgery where they can't go over 90. That's what we give them. So it's more seated shoulder shrugs, keeping everything below 90 here. So those were the less than 2 weeks post-op, but typically we don't see them that soon, but that's what we would kind of give them. The lymphedema exercises that we sent, it was the little stick figures. Basically what we want to do is usually with lymphedema, we talk a lot about belly breathing. And so belly breathing kind of is the biggest hose in the body. So we wanting to kind of prime the system. So what these exercises are, they're just meant to do their own drainage. So it kind of starts with 10 belly breaths, and they'll do head nods, bring their head up and down, shoulder shrugs. So they start at the top of their head and they work down. They'll bring their arms up and down for 10 times. They'll bend their elbows 10 times. They'll flex and extend their wrist. So that's just more, I tell people to do that throughout the day as a way to circulate the lymphatic system as they're working or whatever they may be. So that's what the stick figures are. But again, bulk of what we do is the stretches of the exercises that we gave you, this for their own kind of drainage technique, and really focusing on posture. And that's kind of it. So I think we're right on time. Questions on kind of more of the practical part of what it would be like to see a patient, like for an evaluation of the things that we're focusing on, or anything that you have for Sarah as well?
Can you show a little bit of lymphatic manual drainage?
Sure. So, well, I guess we can just kind of do it here. It's kind of, because of where the lymph is, it's just a general light stretch. It's not a massage where you're in here and so if I was working on webbing or cording, I'm in here and I'm trying to kind of get the tissue, or if it's radiated fibrotic tissue, I'm really getting in there trying to stretch and mobilize it. Manual lymph drainage, we're trying to direct the fluid to wherever the part of the body that's not affected. So if it's affected here, we're trying to kind of move it other places to get it going. So it's a skin stretch. So it's a very light, and so you can do it on yourself where you're just feeling the skin stretch. So it's kind of right on the top surface. So there's a whole sequence that we would open up the head and neck area first, and then we kind of open up in the axilla. We open up on the side, and we do a lot of manipulation of the abdomen. Well, actually, that would be first. They start with their belly breathing first. We manipulate the abdomen. Go ahead, here real quick. So we want to, if this was the affected side, we usually kind of start at the head and neck. And so it's just skin stretching. That's what manual lymph drainage is. We're stretching the skin, so we're kind of helping the fluid have a place to go. And then we would open up the neck. We would open up the axilla. You would open up the sides. And then you do a lot of stuff in the belly. Pre-COVID, I would have patients do a lot of belly breathing with me in the clinic. But with COVID and masks on, I just kind of do a lot more of my own belly work, and I have them do belly breaths just because of the breathing aspect. But that's kind of what manual lymph drainage is. It's very light, it's very gentle, it's skin stretching, and you're trying to redirect fluid to other places that the body can absorb it. Did that again, we could spend 2 hours on a whole routine.
Amazing. They might want you back.
Anything else other than the chat? Because we can't see the chat.
Very comprehensive 2-hour lecture. Thank you. Thank you in advance.
You.
Thank you
Could
very
you
much.
please, could you please demonstrate upper extremity edema reduction sequence?
Oh, that's the stick figure, the belly breathing, the head nod. So it's you do you start with 10 belly breaths, you head nod 10 times, head turn 10 times, you shrug your shoulders. Again, that when I do that, I'm stretching the skin, and so I'm having the fluid move easier.
It's like massaging the lymphatic system from the inside.
And then you do the shoulder shrugs. There's chicken wings, or sometimes I just have patients reach their arms up, so they're going to get the drainage here. You bend your elbows, so then I'm getting that skin stretch right here, and then my wrists, and then you can just squeeze your hands, and that's all it is. 10 times, like 3 times a day. But the belly breathing is the first thing that you do. If patients turn their head and they should have, not, it makes no difference. They just start at the head and work their way down to the arms and the hands.
One last question. Could you share a schedule for advice for the patient?
Well, if somebody does progress into an actual chronic lymphedema, they have if they are showing on lymphoscintigraphy and in our clinic that they have pitting edema, that it tends to maybe be a little bit better in the morning and progressively gets worse in the afternoon, it really is a stage 1 lymphedema. And at that point, if they do progress with those symptoms without a measurable difference, when they start having actual lymphedema, did a compression glove. Usually it's the first thing you put on in the morning when you wake up, and it's the last thing you take off before bed. And the reason why compression works is because it works this is why it's most important during the day. Compression is ineffective. Muscles are pumping, it's helping to propagate the lymph. And when you have compression on against the movement of the muscles and the contraction of the muscles, you have a dual force pushing and propagating that lymphatic system back to central collectors. So first thing in the morning when you wake up, last thing before you take off, just during the day. And if you have chronic breast cancer related lymphedema, you always wear a compression sleeve.
I have to tell you that I've been working with these for 7 years, and this is the largest group of participants, 108 people. So amazing, amazing, amazing. Mr. Tan, what do you think? Was it worth it?
Yeah, I agree, Connie.
Very much, very much.
Very much a lot of the launch.
Full of knowledge and practicum. Thank you very much.
Yeah.
So we hope to see you again in April, and cannot say thank enough for the speakers and Connie who arranged everything behind the scene. Have a good evening, everyone. Thank you.
Thank
Okay,
you.
ครับ Thank you very much ครับ
Bye.
and you have to do like the evaluation form after this session, and please check out the time after this finish. Okay, thank you everybody. Thank you Sarah and Amy. See you
Thank
again
you.
next time.
Thanks, Sarah, Amy.
Okay.